My name is Candice Ward. I am a diabetes clinician and I lead CDEP, and I am going to be your chair today. I'm going to hand over to Helen. Helen is going to take us through the slide deck and present the information, and then we're going to have a Q&A session once she's finished. Thank you, Helen. Take it away.
Thanks, Candice. So as mentioned, I'm Helen. I am a programme manager at NHS England, and I manage structured education courses that are implemented at a national level. So thanks very much for joining us this afternoon at lunchtime. Thank you for giving us the 45 minutes that we intend to spend together. And what we want to do this session is we want to be able to support you to understand better the benefits of structured education, be aware of the offers that are available and the evidence behind them, and also increase your understanding of the referral routes into the services, so that then as healthcare professionals or people working with people living with diabetes, you are able to offer the most appropriate service to your service users. So, just a bit of background on why we're talking about structured education and why, as NHS England, we decided to deliver some structured education services. In the long-term plan, we committed to further expanding provision of structured education, and particularly digital self-management support tools. The reason for this was, at the time, it was identified that uptake of structured education was really poor. That was identified in the National Diabetes Audit, and there was also lots of research to suggest that there was various barriers to attending structured education, and so digital was one of the ways of addressing some of those barriers. So, as I mentioned, we nationally commissioned a number of digital structured education programmes in order to reduce variation across England, in order to access online support. It was to increase patient choice and also to try to improve overall attendance at structured education. So just a bit about structured education. Research has shown that diabetes is a progressive long-term condition that is largely self-managed. So there's certain research that suggests that people spend a maximum of 3 hours with a healthcare professional per year. So it is largely self-managed. And non-attendance at education was linked to a fourfold increased risk of developing complications. Structured education has been proven to provide the knowledge, skills and confidence to successfully self-manage. It can also support with reducing diabetes related to stress, improving health and well-being, reducing HbA1c, maintaining or achieving a healthy weight, but also increasing confidence in making decisions about health and treatment options. Not only that, it is backed by NICE guidance, which recommends that structured education should be offered throughout the diabetes pathway. So that is at diagnosis, but also reinforced at annual reviews, and wherever possible to encourage people to engage with education and inform themselves on how to self-manage and take control of their care. So there's a really important place for structured education within the diabetes pathway, supported by NICE and also things like QOF. The reason that we as a national team focused on digital services was because there was already at the time very well established face-to-face services, so we didn't feel that there was a need to provide additional services there. But what there wasn't at the time was significant coverage or availability of digital services. And so we wanted to reduce that variation of availability of digital services that had happened through varied commissioning at ICB level, and instead provided national coverage of services for adults for type 1 and type 2. We also had some significant evidence from research evaluations of the benefit of digital services, which hadn't previously been available. So it suggested that there was space for digital services to be developed and rolled out at scale. And also there was lots of research that suggested that there are barriers to attending face-to-face services, which digital services can overcome. Now, I want to be really clear here that we know that there are other challenges that are raised by digital services. So we don't assume that digital services address everything, but it allows for choice and it allows for addressing some of the barriers and issues of face-to-face services, so that then it allows for choice and people to have more options to actively engage in education. And so we know that there is not one size that fits all. It is just about making sure that there are more services available to suit more people. And as you can see on the right hand side, part of the reason and the data behind needing to increase structured education attendance was that only 7 in 10 people were being offered structured education at the time. There was 3 to 6 month waits for face-to-face services. And then the recorded uptake, according to the National Diabetes Audit, was only between 7 and 10%. So even where people were being offered at a relatively high rate, the actual attendance wasn't that good. So this was the background and reasoning for why we wanted to try to offer additional opportunities to engage with the services. So I'm just going to briefly touch on some barriers to attendance before going into the different types of digital services. And the reason why we wanted to focus on some of the barriers to attendance in this webinar is that it's really useful for you to be aware from research the types of issues that people have raised about their attendance at structured education, because that research also did find that people living with diabetes would have been encouraged to attend structured education if they felt that their healthcare professionals had explained what the service did for them, or had a bit of more of a conversation about the value and the importance of structured education. So we wanted to just highlight that there may be various barriers to attendance that people raise, but it's really useful as someone who is working with service users and patients to be aware of some of these barriers and some of the ways that we can overcome them through providing digital services. So on the left of the table, there is the barriers that were identified by the research, and some of the solutions of digital services are on the right. So the first barrier was perceived self-efficacy. So this is where people felt that they didn't need structured education because they knew enough about their condition, or they felt that they were managing quite well. And that is a really positive thing to hear from people living with diabetes, that is the case. What we do know is that ongoing access to tools provided by digital services can help manage and maintain that self-efficacy. We've also found from the delivery of our national services that actually people who have been living with diabetes for quite a long time and who thought that they were managing quite well have actually still managed to learn new things and implement new tools and tips that we have provided them with, and made really positive changes to their self-management. So even where there is perceived self-efficacy, there is still opportunities to learn more and to potentially improve that self-management. Low prioritization was a really key barrier for a lot of people. So this was particularly important for people who had other conditions as well as diabetes to manage, because there was a lot of different appointments and different information to navigate. So people found that they would deprioritize diabetes self-management because they considered it, and this is in their words, they considered it as less critical, less important, and that they needed to spend less time on it because potentially the ramifications of not learning more about the conditions weren't as important as, for example, dealing with another condition that they had, or particularly for people with type 2 diabetes, they would see that the complications were something that was really far down the line, didn't need to think about it immediately. So it's really useful for thinking when you're talking to service users about this potential low prioritization of education, because what we are finding from other work that we're doing with patient insight is that, particularly at diagnosis, people felt that they didn't get enough information, and that they regret not having information and education at the time. They feel that they would have done things differently with their self-management if they had felt more informed. So actually, the insight from people living with diabetes is actually starting to increase that they would actually like to have additional information to support their self-management. But also with the digital service solutions, it does mean that they are accessible at any time for when a person is ready to engage with their own self-management. So even if now isn't the time because they have other priorities or other things going on in their lives, or the commitments that mean that they can't engage at the moment, it does mean that they can access it whenever they are ready to come back round to getting access to that information. And also because it's bite-sized content, it does allow for that small chunks of information that can be timely, so that can also support engagement around other priorities. So what we do try to encourage is that actually even just 5 minutes of reading an article when you're on the bus on the way to work, or you know, whilst the food is on, cooking tea. It's about like engaging just with some content, because once you start getting more informed, you're more likely to actually continue that engagement and learn more. So it doesn't need to be everything all at once. It can actually be over a period of time. So that is something, again, where digital solutions can be quite helpful, because it's not that quite condensed, intense course. A further barrier that was identified was limited knowledge about structured education. So this one in particular is where healthcare professionals can have a really big influence, according to the research. They found that people living with diabetes said that they would have attended structured education if a referrer had been positive about structured education, if they'd explained that it was an essential part of care and not just something that they could do if they wanted to. And that would have completely changed their attitude to attending what doesn't sound particularly interesting when you call it structured education. It doesn't sound like it might be something that you want to engage with. So it was really key for people that actually, by someone being positive and actually explaining what the point of doing the education was and how it might support with reducing complications and making their life easier with managing the condition, that they would have actually engaged with services. Also, something that we have is that with digital, you can have a quick registration. So actually that easy access means that people can just try it, see if it suits them. And if it's not for them, then they can disengage, but it gives them that easy way into getting information that they need. And we do find, again, with our current services, that people do pick and choose what they look at. They may just pop in, register, have a quick look, and then go and do something else. And then other people might come in, look at everything all in one go, and sit and go through all the content in one go. But it just means that people can pick and choose the way that they learn, and just at least have the opportunity to access something and have something that is trusted because it's NHS content. And then the final barrier that they mentioned was practical barriers. So this was in relation to face-to-face services. So things like transport to the venue of the service, and also that quite a lot of them happen during working hours, which means having to take time off work, etc. So in this sense, the digital service solutions can support that, because they can access the content at a time that suits them around their other priorities and commitments. There is no physical requirement to be at a certain place at a certain time. So this flexibility means that they can still get that same important self-management information whilst addressing some of those practical barriers. So I will now just move on to the detail of the different services that are available. So the first one that I'm going to talk about is healthy living. This one is for adults with type 2 diabetes. So healthy living is based on a randomized controlled trial by University College London, and it proved that it reduced glycemic, it improved glycemic control over 12 months, and there was a reduction in diabetes-related distress for those who were most recently diagnosed. We've had over 56,000 users registered to date, and we are doing an independent evaluation to evaluate the health outcomes from usage now that it has been implemented on a national scale. So we're expecting that information to come through in the next 3 to 6 months, which we expect to replicate the same as the original evaluation. The implementation benefits are just outlined on this slide. So the things that we have found from direct feedback from these services is that people living with diabetes have found it positive because it is self-directed, so they can complete it at a time and pace that suits them, and it's web-based, so they can access it again at a time and place that suits them. It is free to access, it's a quality service, so it has gone through various accreditations, including Kismet and Orca. It's evidence-based, it's available 24 hours a day, and there's an option for ongoing management in addition to face-to-face structured education attendance. So again, just mentioning that we don't think that it's an either or for face-to-face and digital. There is a place to do both, and that digital can actually support that ongoing learning that a face-to-face course provides that intense initial information, and then the ongoing management can be supported by digital access, because who hasn't gone to a course and then needs refreshers after a certain amount of time? So it's quite important to have that ongoing management and refreshing of knowledge. And then just for healthcare systems, all of the ones at the bottom are the same as for people living with diabetes, but also implementing the service is eligible for QOF. There are no capacity limits, and also there's a lot of implementation resources and data packs that are readily available. So this can support systems and healthcare professionals to be able to implement this service. It's all already done for you, so it's just a case of accessing that information, which we will be sharing at the end of this webinar. I thought it was quite useful just to share a nice case study from this service. So this is Janita. She used the service and she managed to lose 9 stone. She also said that the best bit of the program was that she was able to go on holiday with her children for the first time ever, and they had told her that it was the best gift that she had ever given them. So Janita is just one example of how, making herself aware of additional self-management options, learning about exercise, learning about eating habits, learning about self-care. She then implemented them, and she has benefited from the program in this way. The next slide just shows a few more examples of some of these, some of the feedback that we get. So it's not just about weight loss. Some of it is around that confidence to self-manage. It's around feeling informed, feeling like people then know how to manage the condition better, feeling empowered, and also obviously the healthcare benefits as well are shown through these as well. So just a few examples, but we do get user feedback both from people who are newly diagnosed and people who've been living with diabetes for a long time, and both are finding the program very useful, sometimes in different ways, sometimes in the same way, in terms of it being the first time that that they've accessed information in this way. So some positive messages there. In terms of referring to the programme, excuse me, this again will be circulated after the webinar, but there are several options. So users can self-refer, so there's opportunities to promote the service through communication campaigns and things like that, making people aware of the self-referral landing page, which is linked on there. But there's also two ways that healthcare professionals can directly refer into the programme. So one is a direct referral where it's a referral form that can be sent into that email address, and there is also the bulk referral route where we have letters and text messages that can be sent to whole practice registers, and both of the GP practice routes do qualify for cloth achievement. There is an example here, just very briefly, around a best practice case study. So in Bedfordshire, Luton and Milton Keynes, they went through the bulk text message process, and 10% of their whole type 2 diabetes population across the ICB registered in a 6-week period. They managed to do this for a very low cost, and as mentioned there, the way that they managed to do this was by pre-building clinical searches and providing text messages, copy and resources, which we have available. So if you are interested, we can share those with you. They did note that incentives did encourage activity, but they aren't necessary because of that QOF incentive. And also, again, mentioning QOF achievement is available for relevant referrals, and it's for very limited staff time and upfront cost. So we can provide further information about this case study if you want to get in touch with us after the webinar, but just a very quick overview of the success of that referral activity. So the next service that I just want to briefly talk about as well is My Type 1 Diabetes. So this is the other national service that we provide for adults with type 1. It's on the right hand side, there's just an image of it, how it looks on a mobile phone. So it's NHS branded, which helps increase trust in the information that's provided. It includes tailored advice and educational resources, and these have been created by NHS experts and people with diabetes. It aims to support users to gain more understanding of type 1 diabetes and increase confidence in how to manage it in the same way that Healthy Living does for people with type 2. Again, as with Healthy Living, it's web-based and optimised for use with multiple devices. It's free to healthcare systems and to the participant, and it's been used by over 9,000 people to date. So for this service, there is content that is available without having to register, but then there is also additional content and courses once a user has self-referred and registered for an account. So this service doesn't need any direct HCP referral activity. How this one can be accessed is through self-referral only, but again, that means that it is possible to provide leaflets and information about the service so that then people can go and look at the service at their own pace. So again, we have various communication methods, and we have printed resources if you wish to access those for this service. So some user feedback for the My Type 1, very similar again in the sense of about being more informed, feeling more confident, again, impact on healthcare outcomes as well being identified, and just how easy it is to use, and how informative it is. These examples, a lot of these are for people who have been living with diabetes for a long time, yet they are still finding that this service is really useful, and that they're learning new information. For example, that one on the right hand side, they're learning new things even after 30+ years. So it is really, again, reinforcing the need that actually it's not just a diagnosis, it's that ongoing management and ongoing encouragement to join an education course at annual review or at any point where there's an opportunity to encourage engagement with information about their self-management. So just to summarise some key messages, structured education programmes are effective in improving health outcomes, in reducing complications and also reducing costs in the long term for the NHS. Referrers do have a really big influence on people's willingness to take up structured education, and the way that they can do this is by being positive and enthusiastic about the benefits of structured education, and also supporting people living with diabetes to understand that it is an essential part of their diabetes management. Referrers are encouraged to make best use of locally or nationally commissioned face-to-face and online services, and as I mentioned before, it's not a case of either or. It's really important that there is multiple options for people in place, so that then they can choose something that suits their learning needs best. And just to final note on that is that online services can help provide that patient choice, and they do address some of the barriers to attendance of face-to-face courses, with the caveat that we know it doesn't address all barriers. And they also can support continuous self-management. So I mentioned that there is a lot of additional resources that we have for the programmes. These links will be available through the circulation of this pack, but you can download various resources from our future NHS sites, and also we have printed resources available, so leaflets and business card type items for both Healthy Living and My Type 1, which we will pay for. So if you want to have printed options for it in your services, then please feel free to click on the links, register, and we will get those shared out with you. And I will stop there and hand back over to Candice.
Great. Thank you very much. I'm going to stop sharing so we can have a good conversation. And there are lots of questions in the chat. Thank you everyone for asking questions. We will maybe have some time to cover them all. So if you do have anything burning, please do continue to share questions as you go along. So one of the questions that has come up is if somebody, you know, like a healthcare professional myself, I kind of want to understand what the course is about. Can I see the course? Can I self-refer? What's your sort of suggestion?
Yes, so for both courses, it is possible for a healthcare professional to log on and join the services, so that then you can actually see what they deliver and familiarise yourself with the options, which we really would encourage you to do, so that then you can better explain them to your patients and service users. So yeah, please do feel free. So you can self-refer to both services at the links that are available in the presentation.
Great. And then sort of languages, obviously we've got a very culturally diverse population we're supporting, you know, is that accommodated in these courses?
So in My Type 1 it is delivered in 9 languages, which I'm afraid off the top of my head I can't remember, but there is information in our FAQs that will get circulated afterwards. In Healthy Living, it isn't currently available in different languages, but we provide information about how it is possible to translate it online. And that is in line with the way that NHS.UK deliver their translations. What we have found is that actually translated copy isn't necessarily the right way to go for all education, and actually there are opportunities to deliver courses in people's own languages, which is better suited than potentially delivering it through a digital service that's translated. On Healthy Living, we have also provided culturally adapted dietary advice as well. So whilst it's not the language point, I just wanted to highlight we have done some cultural adaptations around the dietary advice.
Great, thank you. And then there's a question about sort of Daphne and Desmond. Sort of how does Daphne and Desmond differ to the offer that you're suggesting that the NHS provides?
So both of those courses are also evidence-based, and they are provided both face-to-face and online. So there is a space for all of the different services that are available. It was that at the time there wasn't national coverage of online services, and so that's where we were trying to meet the gap. So we don't actually mandate that these services are used. It's just about making sure that there is a service available to your local population. So it will be relatively similar content. It was just about ensuring that there is something that is available nationally to anyone who does want to access it, and then it avoids any variation in commissioning. So if in your local area you are using Daphne or Desmond, then do continue to use that. You are welcome to still look at these services to see if there is still a space for making use of these services alongside Daphne and Desmond. But like I said, it is about having choice and having something available everywhere. So if you have a locally commissioned service that already suits the needs of the population, then it may be that these aren't necessary in your area.
I like what you said earlier about offering variety and choice, and also sort of an ongoing. So somebody might have done Daphne or Desmond a couple of years ago, and actually this is a part of that ever-evolving journey of living with your diabetes. So I quite like that sort of being able to combine.
That's right. It's quite complementary. So if someone has done something face to face, they might then still want to continue learning or come back to some of the content in a year's time, in 2 years' time, whenever. And so that digital availability means that they can do that. So it can be a mix and match kind of situation as well.
And I suppose that lends it to itself. There's somebody here who works in prisons, and obviously it's harder to sort of attend structured education courses or group courses for sort of that group of people, and so they're often sort of left behind because they don't have that access to education. So, would this be something that they could potentially access?
Absolutely. The only real requirements for accessing the service is that you have access to a device. So you would need to have access to either a phone or a computer, but otherwise there is no restrictions on access. So if it's possible to use, it would be possible to be used in prison.
That's great. And then there was a question about there are other sort of courses like the diabetes prevention program and weight management courses for how do those fit in with healthy living and my type 1?
That's a really great question. It is something that has come up a few times, and understanding the differences and the different pathways. So the diabetes prevention program is for people who are pre-diabetic. So they will only take on referrals from people who are have pre-diabetes. The weight management program has criteria where it's specifically about dietary advice. And there is criteria there again around people who are over a certain BMI can access that service. Structured education, so Healthy Living and My Type 1 is available for everyone. So even if there is a requirement to lose weight as part of self-management, structured education is a bit broader than just dietary advice. So structured education can fit alongside the weight management program, because it was also about practical advice, navigating services, about self-care, even things like driving, working with diabetes, things like that. So structured education does sit alongside the weight management program, and the key difference is just that the weight management program has a referral criteria of a certain BMI to be able to be taken on by that program. And apologies, I can't remember that at the moment, what that criteria is.
Perfect, no problem. And just to confirm, who sort of geographically, who is eligible for the Healthy Living and My Type 1 program?
So anyone across England is
England.
Yes, England.
Okay. So not across the whole of UK, just across England, because that is kind of one of the questions that has come up. And then we've got a wide, diverse audience here today. And so one of the questions was, can you just explain what QOF is?
Yes, so QOF is a quality indicator that's is used in primary care, and yeah, so it's used in primary care. And someone's also just answered the BMI. Thank you for that.
Awesome. Thanks, Claire.
Thank you. So it's used in primary care to support with incentivizing certain activities. So in this case, the incentivization is about referring people into structured education within 9 months of their diagnosis. And anyone who fits that criteria there'll be a payment to the practice. So at the end of the financial year, I believe, it's all of the records are updated, and the financial incentives are calculated based on how many people have met that need. So it's a way of encouraging practices to be referring people into structured education at diagnosis, because that's when it's considered to be the most timely. Even though it's beneficial to have structured education at any time, the incentive is about within 9 months, because it's then has the most benefit. It's when people most need it, because they are navigating a new condition, and it is proven to have the most benefit if people have access to it earlier on in their diagnosis. I hope that answers sufficiently.
Absolutely. And then there's something just else as a question from somebody else. Do you get the same QOF points no matter which sort of, so long as it's structured education? Is it across the spectrum, or do you get more QOF points for sort of healthy living than you might for expert, or vice versa?
It's the same. So yeah, we are considered equivalent to the other structured education courses, and it's actually the same SNOMED code that applies to Healthy Living as it would to Desmond or any of the other services.
Great. And then I think we've got time for sort of one more question. There's a sort of a request to just go over, what are the heavy hitting points around why should somebody living with diabetes, either type 1 or type 2, do structured education? What is that, magic key? What's the research show that really makes a difference to them?
So it makes you live, it helps you to live better with the condition. So I think that's the real caption of it, is that you can live well, live better with your condition if you understand it better, and understand how to live with the condition better. So I think that would be the summary. But on the, just to extend that slightly, so it's about managing your health outcomes and keeping them in a healthier range. It is about being informed and feeling in control and empowered to manage your own condition. And it's about being able to know what you're entitled to from the NHS, and how to navigate the condition, and how to access support for the different needs that you might have through the course and life cycle of your condition.
No, absolutely. So, huge benefits for people living with the diabetes. And then I suppose for the NHS, because we know that diabetes, unfortunately, is a huge impact on the individual, but also on the finances of the NHS and treatment costs and, loss of economic active adults and various other things. So it's a win-win for everyone, both for the NHS and people living with the condition, to be able to self-manage better, prevent those awful complications that unfortunately can occur, and live happily and kind of without that mental burden. Absolutely.
That's
Just going to
right.
have one more scan, last opportunity for anybody to answer or ask any questions. We've had a few come up around sort of resources, and we promise we will send you an email with a certificate, with the slide deck, and a full pack of resources that you can access everything we've spoken about today. We will also be sharing with you the links so that you can get hold of NHS England and the team there to order your posters and your flyers and business cards, or whatever you feel you need as part of supporting people get onto structured education. But it is certainly something that we would encourage. Right, I think with that, we are going to start pulling the section to a close. As I said, we will be in email contact within the next week or so, sharing all this information with you. But if you haven't received anything, please get hold of us at CDEP. And I will just quickly share my screen again and give you that information on how to get hold of us. So you will see this email, but here in info@cdep.org.uk is how you would get hold of us should you not have heard from us and received your attendance certificate, your slide deck, and all the implementation information. So thank you very much, everyone, for attending this Lunch and Learn webinar. Thank you, Helen, for taking us through that detail. That was great. And please do, when you leave us, there is a survey that will be shown to you. Please complete that. It really gives us some great feedback about other sort of webinars you may be interested, or information you'd like to hear from, and then also just feedback about this webinar or anything that you'd like to share with us. So do take some time to complete that if you have a moment. But I'd like to thank Helen again, thank the audience again for attending, and have a wonderful rest of your day. Thank you very much, everyone.